Thank you for joining us for our discussion about abnormal uterine bleeding. Today, Dr. DeStephano will provide an overview of this condition as well as answer questions from live viewers near the end of the broadcast. Thank you for joining us today, Dr. DeStephano. Would you mind telling us a little about yourself?
Yes, thanks so much for having me and the invitation. Abnormal uterine bleeding is a focus of mine as a minimally invasive gynecologic surgeon at Mayo Clinic down in Jacksonville, Florida. We also have minimally invasive gynecologic surgeons in Rochester and in Arizona, so that women can have abnormal uterine bleeding evaluated further and treated in a surgical or non-surgical fashion.
Thank you. Great to have you with us today. Let's start off with a few questions that are asked frequently. My doctor recommended a hysteroscopy. Is anesthesia required for that?
Anesthesia is not required now with most hysteroscopies that are done in the office. Usually when we do hysteroscopy in the first place, it's for diagnostic purposes, and we're not removing anything. And so it's similar to an ultrasound. And so over 90% of diagnostic hysteroscopies, where we're just taking a look inside the uterus, can be done with no anesthesia. And I have one prop here that kind of shows why. So this is our uterus here, and this is an endometrial biopsy pipelle. And this is very commonly done in the office, but you can see here how small the pipelle is. This is similar to the camera that we use in the office to take a look inside the uterus to further evaluate abnormal uterine bleeding.
Great, thank you. Is going home the same day after a hysterectomy safe to do?
It now is. Previously, hysterectomy meant 3-4 days in the hospital or even up to a week, but with the incisions we're using currently, and here's a typical trocar that we'd use for laparoscopic hysterectomies, patients can go home on the same day with high satisfaction and no increase in the complications.
Wonderful, thank you. When should one be concerned that vaginal bleeding may be caused by cancer?
This is a very important question that a lot of women have, and so there's a few things to think about. First is obesity. So there is a higher risk of endometrial or uterine cancer in a woman that is obese, and so I have a high index of suspicion and would get further sampling and get a sample within the uterus if a woman is obese or overweight, because that is a risk factor for cancer. The other risk factor is a woman over 50 or postmenopausal that has bleeding. If a woman goes many years without bleeding and all of a sudden has bleeding, then this could be a sign of cancer and it should be evaluated further.
Thank you, Dr. DeStephano. What can a new mom expect after delivery?
So typically in the first 6 weeks after delivery, there is the risk for some bleeding just from the recovery and the repair after and the body's healing process after delivery, both C-sections and vaginal deliveries. There can be some bleeding. Just like after a hysterectomy, there can be some bleeding after removal of the uterus. And this just comes from the healing process. After that 6 to 8 week window, if a woman is breastfeeding, this can actually reduce the amount of bleeding a woman has. She may not have a period for many months if she's breastfeeding, and that's because an egg isn't produced every month while a woman is breastfeeding. However, it is still important to consider contraceptive options and birth control, as a woman can still become pregnant while breastfeeding. Once a woman stops breastfeeding, the body typically starts to ovulate and the cycles return back to where they were before the delivery.
Great, thank you. Can cancer be spread by performing a hysterectomy or myomectomy in a minimally invasive fashion?
In 2014, there was a lot of media attention on what's called power morcellation. This was an instrument that was used to chop up fibroids into smaller pieces in order to be removed from small incisions. many times this wasn't done within a bag or in a contained fashion. And so there have been cases reported where cancer was likely spread. However, this was very rare for it to be spread. And now the Food and Drug Administration has limited and restricted the use of power morcellation. And so power morcellation is rarely done. And when it is done, it can typically be done in a more contained fashion within a bag. And so we actually do not use the power morcellator at Mayo Clinic in order to theoretically reduce the risk of spreading cancer. We put the specimen in a bag and then either extend one incision or remove the bag from the vagina in order to theoretically prevent the spread of cancer.
Great, thank you. If you're just joining, this discussion is about abnormal uterine bleeding with Dr. Chris DeStephano. We'll take questions from live viewers near the end of the broadcast. Dr. DeStephano, how does an IUD actually treat the underlying cause of heavy menstruation? Aren't the hormones just covering up the problem without identifying the root cause?
This is a great question that comes up a lot. And I actually brought another prop, an intrauterine device, with our uterine model here. And so I will show the intrauterine device and what it looks like going in. And so that's the process there for placing an intrauterine device. It's a very simple office procedure that can be done without any further workup before placing the intrauterine device. However, there are cases where the intrauterine device would not be recommended because of an underlying issue that wouldn't be able to be treated by the IUD. And these can be like a polyp, a structural abnormality within the uterus. If there's a polyp, a fibroid, or a higher grade cancer, we would not use an intrauterine device in those cases. And so if a woman has had abnormal bleeding despite oral contraceptive pills or other medical treatments, then we would recommend further evaluation before placing the intrauterine device. But the reason this is a good question is that when a woman becomes 40 to 50-year-old range, the hormones fluctuate and change, and so this can often lead to some of the abnormal bleeding as well. And what the intrauterine device does is it thins out the inside of the uterus in order to stabilize some of those hormonal fluctuations. So in fact, the intrauterine device is actually stabilizing those hormonal fluctuations and getting to the root cause of what's causing the bleeding.
Thank you. That actually leads to the next question, which is from a woman who is 44, said she had normal periods her entire life, and now they are suddenly heavy and irregular.
And this gets back to that kind of 40 to 50-year-old range, what's called the menopause transition. And when a woman enters the menopause transition, it is very common for significant hormonal fluctuations. And so those normal periods and normal kind of hormonal fluctuations that a woman had in her 20s and 30s may suddenly become abnormal and lead to abnormal uterine bleeding. There can also be the development of a polyp, a fibroid, what's called adenomyosis. And each of these will need to be worked up further in order to get to the root cause of what's causing the bleeding. But in a majority of cases, it is normal to have fluctuations in cycles and periods once a woman is over 40 because of those hormonal fluctuations.
Thank you. Can you walk us through the process of the general practice workup with abnormal uterine bleeding all the way to being set up for surgery at Mayo Clinic?
Thank you. So typically, if a woman's already had the workup somewhere else, we're able to review those images, the ultrasounds, the biopsy results, and we can see the patient, have the consent signed, and post it to the operating room. And often this can be done within a week at Mayo Clinic because we get patients to the preoperative clearance process. We want to make sure it is safe to proceed to the operating room. And so this can be done in a very efficient manner at Mayo Clinic. However, if a woman has not had any workup before regarding the abnormal uterine bleeding, typically on the day of the first appointment, we would either do a hysteroscopy where we take a small camera and look inside the uterus, and then also do an ultrasound, get a biopsy, just to make sure this doesn't represent cancer. And then once we have those results, we would be able to schedule surgery and do the preoperative appointment with our clearance appointment to make sure a patient is safe for surgery. But the one thing to remember is that there are many ways of preventing the need for an operating room trip by using oral contraceptive pills, a Mirena IUD, or something called an endometrial ablation, which can be done under light sedation without the need for being intubated or a longer surgery like a hysterectomy. But there are many different options that you'll want to discuss with your physician prior to making a decision about surgery.
Thank you. We have a question from a member of Mayo Clinic Connect. I'm in my late 60s and had a DNC 15 months ago. For the past several months, I have had light spotting toward the end of the month. It feels like period symptoms at times. I had a transvaginal ultrasound and it was negative. How is it this spotting continues to occur?
So there's a number of different things that could be contributing to the spotting. One is whether the patient is on estrogen replacement therapy. If a woman is on hormonal replacement therapy, this can actually lead to bleeding similar to periods and cramping similar to periods. So that would be the first question, if the patient is on any kind of hormonal replacement therapy. There could have been the development of a polyp that isn't being seen by the ultrasound or by the dilation and curettage. And so we would recommend a hysteroscopy to take a look inside of the uterus with a small camera. And finally, there is, like we mentioned before, once a woman is after menopause, there is the risk of cancer. Now that would be rare in your case because you've had a dilation and curettage, which is specifically looking at signs of cancer. So the most likely cause is either some hormonal fluctuations, a polyp, or potentially atrophy, which is actually once the uterus becomes so thin because it doesn't have any estrogen stimulation, the atrophy and the thinning can actually lead to some spotting every month as well. And so all of these things would need to be worked up and evaluated further, but I think a good place to start would be with a hysteroscopy, which is taking a look inside the uterus.
Thank you. We have a question now from Facebook. How long after a polypectomy and ablation will I normally be bleeding?
That's a great question. Typically, if the bleeding is from a polyp and you just do the polypectomy, the bleeding, a woman should return to normal periods within a month. However, an endometrial ablation, Mirena IUDs, all of the minimally invasive approaches, sometimes it can take up to 3 to 6 months for the bleeding to be completely controlled. And so we typically tell patients with the minimally invasive procedures that they need to be patient. They will reduce the amount of bleeding. They may not completely eliminate the bleeding, but it can take up to 3 to 6 months for that bleeding control to happen.
Thank you. Another question from Facebook. What are options for a 21-year-old who is anovulatory, tried IUD and stronger estrogen pills, yet still bleeds every day for 2 years?
Again, and I would be interested to know what the other workup has been, because the oral contraceptive pills or the Mirena IUD are very effective for just the hormonal changes that occur with anovulatory cycles where you're not having an egg every month. So sometimes just resetting everything, removing the IUD or coming off of the oral contraceptive pills can be helpful. But I would also strongly recommend further evaluation with imaging and with a hysteroscopy in order to confirm there's not something like a polyp within the uterus.
Great, thank you. Do you have any advice for women who are trying to conceive but have irregular periods?
And so we would recommend in these cases to get a full workup to look at whether there are issues within the uterus. If there's no issues within the uterus, and this is purely because of irregular ovulation and creating an egg, then there are hormonal agents and medications like Clomid that can be used in order to stimulate ovulation. Talking to a reproductive endocrinologist can often be helpful with this process in order to stimulate ovulation in a more regular fashion.
Great. Thank you, Dr. DeStephano. And thank you for joining us today for our discussion about abnormal uterine bleeding. If we didn't get a chance to answer your question, we will try to do so in the comments section after the broadcast. To find out more about future broadcasts, as well as share your experiences and find support from people like you, visit Mayo Clinic Connect at connect.mayoclinic.org. To request an appointment, visit mayoclinic.org. Thank you and have a great day.
Thanks so much for having me.